Hi guys, I'm Kelly King, a PA in hospital medicine and the creator of Hospital Medicine Cheat Sheets. So today we're going to be exploring bacteremia in depth, a fundamental issue in inpatient care where mortality rates remain between 15 and 30% despite ongoing medical advances. This context is evidence-based and tailored for advanced levels and based off the most recent guidelines that we do have. We'll cover epidemiology, risk factors, when to suspect, classify cases, diagnostic workup, pathogen-specific complications, source control strategies, and treatment durations, all updated through 2026. So let's work together to optimize patient outcomes, and please subscribe for more content like this. So first is epidemiology and risk factors. Bacteremia occurs approximately 100 to 200 cases per 100,000 hospital admissions, with higher rates in ICU and among elderly patients over 65 years old. Overall, mortality ranges from 15 to 30%, and it can climb from 20 to 40% in cases involving Staph aureus. Key pathogens based on 2025 data include gram-positive organisms such as Staph aureus, which accounts for 20 to 30% of cases and is the leading cause of death in this category. Coagulase-negative staphylococci, which are often in contaminants, and enterococcus, which make up 10 to 20% of cases. Gram-negative organisms like E. coli, often linked to UTIs, Klebsiella, and Pseudomonas are also commonly associated in healthcare settings. So risk factors include like indwelling devices like central lines, urinary catheters, which are the major drivers of central line associated bloodstream infections. Other factors encompass immunosuppression, like organ transplant recipients, chemotherapy, diabetes, recent surgery, invasive procedures, hemodialysis, or IV drug use. Older age, male sex, and the presence of multiple comorbidities increase the likelihood of occurrence. According to the 2025 Journal of the Article of Medical Association, persistent bacteremia lasting more than 48 hours significantly raises 90-day mortality to 39%. So next is like when to suspect and classify. So you should suspect bacteremia in any inpatient who presents with fever or signs of sepsis, particularly if they have known risk factors or an unexplained like SIRS syndrome. Red flags include persistent fever lasting more than 48 hours, hypotension, or altered mental status. Additional indicators are new focal symptoms such as back pain, suggesting osteomyelitis, or sudden neurological changes pointing to like septic embolic events to the brain. A key distinction between uncomplicated and complicated bacteremia, as this classification directly influences treatment duration. Uncomplicated bacteremia features rapid clearance, less than 72 hours, a controllable source like a UTI, a removable catheter, and no evidence of endocarditis, no prosthetic devices, or no deep-seated foci. Complicated bacteremia involves persistent positive blood cultures beyond 48 to 72 hours, or endocarditis, osteomyelitis, abscesses, involvement of prosthetic materials, or an undrained source, like an abscess somewhere. For Staph aureus bacteremia, treat it as complicated until proven otherwise, due to its high risk of metastatic spread, which occurs in 30 to 40% of cases, according to the 2025 Journal of the American Medical Association. So diagnostic workup, the first step in diagnosis is obviously obtaining blood cultures with at least 2 to 3 sets drawn before starting antibiotics, spaced 1 hour apart if this is feasible. Always perform follow-up blood cultures daily until they are negative, as this documents clearance and allows you to narrow antibiotics as fast as possible to the most targeted therapy, reducing resistance and side effects. The second step involves identifying the source and any complications through either echocardiography, or just an echo, starting with a TTE and escalating to TEE for Staph aureus cases, prosthetic valves, or persistent bacteremia, as recommended by the 2025 Journal of the AMA. Use imaging such as CT, MRI, or PET scans for symptomatic areas like a spine MRI, if back pain is persistent, to rule out like osteomyelitis of the spine. Additional labs you can check are like a lactate level or procalcitonin and repeat cultures as needed. I would suggest like complicated cases, consult infectious disease early, as this drastically improves patient outcomes. So let's do a pathogen spotlight on Staph aureus bacteremia. Staph aureus bacteremia carries the highest virulence among common cases, with mortality rates of 20 to 30%. Complications include endocarditis in 10 to 15% of cases, osteoarticular infections, which are common in persistent cases, abscesses, and embolic phenomena affecting brain or spleen. Management begins with empiric therapy using vancomycin, daptomycin, linezolid to cover like methicillin-resistant strains. For methicillin-susceptible strains, you can de-escalate to Ansef, which offers superior outcomes. Treatment duration is 14 days for uncomplicated cases, which are rare and limited to removable sources, but extends to 4 to 6 weeks for complicated cases. Always perform a transthoracic echocardiogram and consult infectious disease to see if you need a TEE as well. Okay, so now we're moving on to gram-negative bacteremia. Gram-negative bacteremia often stems from like UTIs or abdominal sources, and it has a lower risk of metastatic spread compared to gram-positive cases, but it can lead to septic shock if resistant strains are involved. A key trial is the bacteremia antibiotic length actually needed for clinical effectiveness study from the New England Journal of Medicine in 2024, with 2025 meta-analysis confirming that 7 days of therapy is non-inferior to 14 days for most cases when the source is controlled and the patient is not immunocompromised. And again, this is for gram-negative cases. Management starts with empiric broad-spectrum agents like Zosyn or cefepime, plus Vanco if sepsis is persistent. Duration is 7 days for uncomplicated cases with bacteremia, but 10 to 14 days or longer for complicated or persistent cases. The next pathogen is Enterococcus bacteremia. So Enterococcus bacteremia is we're seeing rising rates of VRE strains, and it carries a high risk of endocarditis if cultures remain persistently positive. Complications include prolonged clearance times and infective endocarditis in complicated scenarios. Management for ampicillin-sensitive strains involves ampicillin plus gentamicin for synergy in cases of infective endocarditis. For vancomycin-resistant enterococcus, use daptomycin or linezolid and consult ID. Duration ranges from 7 to 14 days for uncomplicated cases, but extends to 4 to 6 weeks for complicated cases or infective endocarditis based on 2025 reviews. So some core principles here: source control and stewardship. Source control is essential because bacteremia will not resolve without addressing the underlying infection site, and delays in this step directly increase mortality. This often requires multidisciplinary consultation, including surgical or procedural involvement, depending on the source. For example, for cholangitis, consult GI for urgent endoscopic intervention to relieve biliary obstruction. In cases of empyema, you're going to want to involve thoracic surgery for a VATS or even IR for a chest tube drainage to evacuate the infected pleural fluid. Abscesses such as intra-abdominal or soft tissue collections may need either IR for percutaneous drainage or general surgery for operative debridement. If drainage fails, through IR. For infected renal stones causing pyelonephritis with bacteremia, urology consultation is critical because they're possibly going to need ureteral stenting and nephrostomy tube placement and eventually removing that infected kidney stone for source control. Endocarditis often requires cardiology and cardiothoracic surgery input for valve. Well, it pretty much always involves cardiology and cardiothoracic input for valve repair or replacement, especially if there's heart failure, uncontrolled infection, or large vegetations. Osteomyelitis arising from diabetic foot infections, or you're going to want to consult podiatry, vascular surgery, or orthopedic surgery for debridement or amputation in severe cases, and wound management to remove necrotic tissue. Other examples include infected prosthetic joints, which demand orthopedic surgery for removal and replacement, or central line associated infections, which you're going to need to remove the line. And if they're on dialysis, then you're going to need negative blood culture results before you can replace a new line. In all scenarios, prioritize source control within hours to days, as the 2026 IDS, Infectious Disease Society of America, and European Society of Clinical Microbiology on Staph aureus bacteremia stress that inadequate source control is a primary driver for treatment failure. For antimicrobial stewardship, de-escalate antibiotics quickly based on culture susceptibilities and ensure an oral switch in stable patients after initial IV therapy to reduce hospital length of stay. Implement a bundle approach with early cultures, antibiotics within 1 hour for sepsis and infectious disease consultation. So, key pearls: never use a short course regimen for Staph aureus bacteremia without a full workup to rule out metastatic complications. The new standard for gram-negative bacteremia is 7 days if the source is controlled. As per the 2025 Insights from the Bacteremia, indicates a complicated case, so extend therapy, investigate thoroughly. Major drivers of mortality include delays in source control and inappropriate empiric antibiotics. Early and aggressive treatment can reduce risks by 30 to 50%. So data sources include the Journal of the American Medical Association, New England Journal of Medicine, and Infectious Disease Society of America guidelines through 2026. So managing bacteremia requires precision, suspect it early, control the source effectively, and tailor the treatment duration appropriately. If you have questions, comment in the link below, and always lean on your infectious disease colleagues for help if you feel like you need it. And always, if you want more information on any of this, you can visit my website at www.medcheatsheets.com. Thanks for listening.